afternoon and thanks for joining us. I'm Judy Simpson. Today we continue our occasional series of programs on men's health and cancer. In partnership with the University of Vermont Cancer Center, our focus this afternoon is on prostate cancer. Joining me is Dr. Mark Plant. Dr. Plant is a Cancer Center member and he is chief of the Urology Division at the UVM Medical Center. Thanks so much for coming in.
Thank you.
Let's talk basically about what a prostate is, what it does, and where is it?
So a prostate is the organ in men that helps in fertility, helps a man be able to, how might we say, feed the sperm so that they can help conceive. Suffice it to say, it's an organ also that as we age gets bigger and can create difficulties because every man pees through it. So it can create some obstructive difficulties. It sits under the bladder.
As we can see here. In the
yes, right under the picture. You'll see it's right under the bladder. And as it grows, we typically refer to it as the walnut that grows to the size of a tangerine.
And tell me a little bit about what prostate cancer is.
So prostate cancer is unfortunately the problem with the prostate, even more so than the urinary difficulties. Prostate cancer right now is a disease process that we can't forget because it remains the #1 non-skin cancer that men can develop, and it remains unfortunately a very important cancer killer. So it remains the #2 cause of cancer deaths in male today.
And so you noted that risk increases with age. Are there other risk factors that people should know about?
Absolutely. Very important for people to remember, especially if their father or brothers have prostate cancer, that they would be at elevated risk or higher risk of it as well. The other one is African Americans are at much higher risk as well.
Do we know why?
We are looking at some of the genetics. There are some genetic mutations that are starting to be figured out with research, but we haven't figured it all out yet.
What about lifestyle? Is that a risk factor?
So there are some reports whereby high-fat, low-fiber diets may contribute to the development of prostate cancer. Even some people have looked, I just came back from our national research meeting, and some people are talking about vitamin D levels. I have to tell you, I'm always a little bit weary about making any strong recommendations. But I always say to my patients, a healthy diet for your heart is a healthy diet for your prostate.
Okay. I assume with most cancers, early detection is important. So what should men be doing or looking for?
So when you think of, what should I be worried about? I want to tell your viewership and all the patients outside that you shouldn't really look for anything. It's not a disease that you should think, oh my God, I'm peeing slower, so I must have cancer.
Right.
I want to implore people to know that, seek help from your doctor if you're having trouble peeing, if you have blood in the semen. As on the screen, if you have any pain in the pelvic area that isn't short-lived, it's not a bad idea to be seen. If you're having bone pains, the other issue too that we don't talk much about as men is if you're starting to have any difficulties getting or maintaining an erection, it's again another very important cause to present to your doctor.
And so we seem to hear a lot of different views on screening and prostate cancer. Can you share with us some of the measures that men should take when it comes to screening?
Yeah, so huge area of controversy because people have, there's a lot of issues with regards to should we even treat prostate cancer. I think the death rates from prostate cancer would suggest that the answer is yes. So the typical ways to be evaluated are digital rectal examination as well as the PSA blood test. If either of those are abnormal, and especially the PSA on repeated tests, not just one, an ultrasound and biopsy of the prostate is still the standard of care for diagnosing and making sure you don't have cancer, but if you do, diagnosing it. And
so tell me a little bit about the PSA test because that's somewhat controversial. It's a blood test.
Yeah.
And what do you look for?
So the PSA test is, it's measuring a protein in the bloodstream. And prostate cancer actually secretes more than 10 times as much as normal tissue. So if someone has a cancer, not infrequently, the PSA level is going to be high. It's a relatively simple test. It's very available. It comes down to, though, what has the PSA, which we've had for 25 years, what is some of the evidence that PSA may have achieved some good? And that's where we get into the specifics of, okay, so what have the last 25 years of using PSA taught us? Well, firstly, one of the things we need to recognize is that the number of men at risk, as you stated before, prostate cancer is a disease, as we age, we're at higher risk of it. Well, the number of men has almost doubled.
At that age.
At that age. And then we look at the death rates. If you look at the absolute number of deaths from prostate cancer 25 years ago to today, the number's gone down more than 40%.
Well, that's good.
That's awesome. And I'd love to sit here and tell you as a surgeon, wow, it's because my surgical skills have improved that much. I would be lying. I think we have improved in some ways with surgery, we have improved in some ways with radiation, but we certainly can't take the credit for that significant a decrease in death rate. So PSA has played a role without question. The other thing we've learned is not everybody who has a diagnosis of prostate cancer needs to be treated. So we have ways to just monitor men. And lastly, there's no doubt we have better treatments for prostate cancer, especially advanced disease. Again, these treatments have come in more recently, so this gradual and steady death rate decline isn't due to these new, better treatments. It's due to something else, and I think PSA has a role to play in it.
Can you go to your doctor if you're getting an exam and say, I want a PSA test, and he may say, well, you know, I don't really do those. Can you insist on one?
I think, thankfully, freedoms are still available to us. I think we can ask of our primary care physicians, you know, to have the test. In fact, it's not that you can't have it, it's that physicians are supposed to discuss with you the risks or benefits. If you come out and say, you know, Doc, I'd feel more comfortable having the PSA if you wouldn't mind, you know, doing it, I don't know of a primary care physician that would have an issue with it.
I guess that the problem with it is sometimes there are false positives.
So there are at times patients with elevated PSAs that it's not cancer. Again, I have to implore patients, if you have one level that's high, that really needs to be repeated. And the other thing is there are many other reasons why you might have a high PSA. So it's not an automatic diagnosis of cancer, and even more importantly, it's not even an automatic diagnosis of a bad or aggressive cancer. But let's make sure of that.
Yeah. And so what is new in prostate cancer treatment, and what new research is out there that people might find interesting or helpful?
There are several areas that we need to work harder on, and we are. The first of which is, you know, as I've just said, not everybody dies of prostate cancer, and not everybody has bad prostate cancer. So some people need only be watched. We don't have the perfect tools to determine that right now. We have some very good tools, but we need to get better. And so there are biomarkers or blood tests or ways that we can look at the actual tissue when we do the biopsy to try and determine, hey, how bad is the cancer you have? Some of that work we're doing at UVM. The other thing we're doing is we're doing better at imaging. So now we're using MRI more to look at the prostate. And lastly is really looking at better treatments, especially for advanced prostate cancer. So again, we've gone from 0 treatments 20 years ago to now about 10 approved treatments for advanced prostate cancer outside of what we had as a standard of care before.
We hear a lot about personalized medicine. Does this relate to what you just talked about, and do you think that this approach is better?
Yes, because I think, you know, we have to be very careful. Cookie cutter medicine may be more efficient. It's not good care. There are so many factors that determine our overall health and how we should be treated that I think we need to put a stamp on each and every patient's care that's specific to their situation, you know, even lifestyle-wise. So not just their overall health, we have to look at all the other factors as well.
But isn't that a lot more work?
It's more work, but you know, I think of, you know, I tell students and residents, I think I have the best job in the world, so that the work and the challenge are worth it.
Well, because no two people react the same way.
Absolutely. And we have to be on the lookout because, you know, we can ascribe and prescribe treatments, but we have to be pretty quick to establish, is it working or not, or how is it affecting our patient?
And so we know that early detection is important, but what about prevention?
So, you know, in terms of prostate cancer prevention, you know, we've gone down the road looking at different things, whether it be vitamin E or selenium, which do not prevent prostate cancer. I try to be very careful about making any great recommendations because it's a very slippery slope. We don't have great evidence to say one thing or another will prevent prostate cancer. But again, I return to heart healthy is prostate healthy.
So it makes sense just to take care of yourself in general.
No question. And especially the other thing I haven't mentioned yet, but activity level is very, very important for one's overall health. There's increasing evidence that is probably important for our staying cancer-free.
So let's go back to the beginning. When should you be screened? What are some of the ways to be screened? Is it definitely cancer? How will you find out?
So again, to look at the broad question, if you're 40 and there's a family history of prostate cancer, or you're African American, you should probably consider screening with digital rectal examination and PSA yearly. That would be the most long-term recommendation. It's the one we applied for 25 years. If you're age 50 without those risk factors, again, yearly screening, digital rectal examination, and PSA testing.
And so when you talk about PSA testing, what's a healthy number, or what would be a number that then you would be concerned about?
So true of everything in medicine, why make it simple? We like to complicate it. I can tell you that the number changes for every decade of life. So 40 to 50, 50 to 60, and onwards, we use a different number. So it's usually 2.5, 3.5, 4.5, and then greater than 6.5 when you're above the age of 70.
And so let's talk a little bit about the Men's Health and Cancer Conference that's coming up.
So there's a morning session being held at the university at the Medical Education Center. It's being hosted by both the Vermont Cancer Center as well as my division, the Division of Urology, whereby men are going to have available to them a series of lectures that are going to address general health issues that are important. It's headed by Dr. Parapato, and he's set up a really outstanding lineup of speakers.
Who should attend?
I think any man or woman, for that matter, spouses who are interested in learning more about men's health and some of the things that can be done, including diet, to better address health and maintain health.
And so any other areas of men's health and cancer that you would like to talk about?
Yeah, I really appreciate the opportunity. You know, it's not just about prostate cancer. It's very important for young males. I implore young males every month in the shower to make sure that they don't have any testicular lumps or bumps. So to perform testicular self-examination. It pains me to say, but young for me is under 35, and I've since passed that. The other thing that's very important, and it's not actually just men, but it's also women. I need to have people understand that smoking is not just about lung cancer. Smoking remains the #1 cause of bladder cancer today. In fact, patients will always ask me, so why is that? It's because of cigarette smoke, as it gets filtered, and there are a lot of chemicals that are deposited in the urine that create, you know, another important and dangerous type of cancer.
That's something that we rarely hear about, too, bladder cancer.
In fact, it is very rare, and it's probably among the least understood or recognized risk factor associations. Patients will come in and say, so I read it's the #1 cause of bladder cancer. What are others? I'll then look at patients and I'll say, well, in fact, I consider smoking to be the #1, 2, 3, 4, 5, and 6 cause of bladder cancer, because the next ones are so rare.
No kidding. We just have about a moment left. Can you just once again reiterate the importance of what men should be doing to sort of spearhead their health?
So I have to tell you, you know, we for decades have had the example of women in terms of advocacy, as well as really being engaged about, hey, we need to address this scourge of breast cancer. It's the same for men. We need to not sweep it under the rug. We need to keep the fight. I think declining death rates of 40% in 25 years, well, we can keep that trend going. It's certainly not stopped, and we just need to keep talking. We need to keep educating each other, and we need to keep talking about the way to stay healthy, which again is keep a great activity level, good diet, high fiber, low fat, lots of water, all the typical things that they have to listen to me in my clinic about.
And especially men who are over 50?
Correct.
I want to thank you so much for joining us today.
Well, thank you so much again for allowing me to be here.
That's our program for today. I'm Judy Simpson. We'll see you again next time on Across the Fence.